Joining us on stage will be my colleague from Phoenix Children, Angela Valdez. She's the point person in our pediatric clinic for vaccines. And I've asked her to kind of sort through the questions that you guys have already submitted. You can sit here and moderate the session, and I'll be backing her up.
Hello. Thank you guys for coming to beautiful Arizona if you are not from here, and thank you to our amazing speakers this morning. I tried to organize the questions that were received through both Zoom and the Slido, I don't know if I'm saying that right, app, and so let's just get started. And if you have any additional questions, please send them either by Zoom or by Slido, and we will keep track of them. So I think there are quite a few questions, but into certain categories. So I think we'll start with vaccine hesitancy first. So I think a lot of questions were answered during this, so bear with me a little bit. But I think the vaccine hesitancy is hard for us as general outpatient pediatricians, and so we're just trying to pick your brain on a few things about the best way to do that. So one of them is, the question is about alternative schedules. And when we have patients who are requesting alternative schedules and they're asking, and I know Dr. O'Leary, you mentioned you hate this question, but how do you respond when families are saying which of these vaccines are most important, or how do we prioritize which vaccines we're giving when?
Yeah, which disease do you want your child to die from? No, I'm joking. No, it's a really challenging question. Is my mic on? Can you hear me? Okay. So it's a really challenging question, and it goes back to what I was talking about a little bit earlier. A lot of it depends on the relationship that you have established with the family. You may end up getting into a longer conversation than necessarily you want. But in general, I say, what I recommend saying is something along the lines of, and you can put this in your own personal communication style, but I have a really hard time choosing between these because they're all, potentially very serious diseases. But I can answer your questions about the specific ones, and maybe we can come to a decision. The alternative schedule issue is very challenging. I think there are actually many physicians who don't accept people that refuse vaccines, but the vast majority of physicians will work with families who want to sort of space things out. And you end up, the tools that Mike shared in terms of communication and some of the ones I mentioned in terms of motivational interviewing, you want to break out your toolbox with those and sort of work with families on doing your best to answer their questions, get the child vaccinated, but trying to keep them in your practice at the same time. I don't have a magic answer to that one. It really ends up often being a very individualized conversation. But working with them, having an open dialogue is probably where you're going to make building trust over time is probably how you're going to get them there. But it's a challenge, and I don't have an easy answer. I don't know if you have other thoughts.
Yeah, I'm in hospital medicine, so I don't deal with this question as much. I mentioned this in my earlier session. The only time I've had families that never vaccinated start their vaccine schedule in the hospital was twice. And it was when I did change my posture and say, you know what, I'm a parent of 3, all my kids were vaccinated on schedule, and I was nervous about it. And I was nervous about it, not because I don't know the data, because I know the data, and I'm a hospitalist, so I see the kids that are sick that get the things that were vaccinated. But because there's so much talk about it, it just made me nervous. I thought maybe I did the work, and we vaccinated on schedule. I'm so glad we did. My son had Haemophilus influenza type A meningitis that's not vaccinated for, and I'll share that story. But it was actually saying that I was nervous about it that the family said that's all I've ever wanted somebody to say. And so again, it was empathy and validating that led to a change, but that's an N of 2. So I think being willing to be vulnerable, I think can be powerful.
Yeah, I do. You saw in some of my cases, I do sort of suggest using your own personal experience, your own personal recommendations. We did a survey where we asked pediatricians what do they think is most effective in these situations? And the thing they say is most effective are these personal, sort of sharing these personal data. Now, when people have actually looked at that systematically, the data are not quite as clear, but at least that's what pediatricians feel like works the best.
Okay. Along those same lines, and I think you both maybe alluded to this a little bit, but can we convince parents who come in saying they want absolutely nothing as far as vaccinations go, and how much time should you be spending on that?
Yeah. So those are really challenging. I think those are the ones where you try to build the relationship over time, and you may get there. But I think most of us recognize those when we start the conversation. And my general suggestion, and I don't want this to come off sounding judgy, but like, kind of don't waste your breath when you sense that, because you're not going to get there, and you're probably going to end up in an argument, and that's not going to be productive for your longer term relationship. Because much of the time when they're refusing all vaccines is they are deep down that rabbit hole, and it's going to take some time. And so the way I recommend, this is how I handled it in primary care, and the way I recommend handling it is just being very good-natured about it and saying, okay, we're, something along the lines of, we're gonna, let's move on, we're gonna agree to disagree about this, but good-naturedly say, this is such an important part of my job, and I believe so strongly in it. I'm going to bring this up every time you come in. I just say, you know me, and usually the families would say, okay, and then they, I don't know, I actually didn't track how many fired me, but usually they would come back and we'd continue the conversation. Sometimes they were ready to talk about it, sometimes they weren't. Sometimes they'd come in with, the spouse who did want to vaccinate who'd say, like, yes, it's time, So it varies, but I think trying to keep that relationship going, but not spending too much time when you've got this, like, massive wall of, I don't want any vaccines. They're not ready to talk about it.
Great.
Okay. And then, so there's quite a few questions as far as PCV vaccine goes and RSV, so we'll just start with PCV. So the question was, what is the initial hesitancy to use PCV 15 versus PCV 20? I guess the question is hesitancy versus confusion on the recommendation. And you explained that a little bit, but what does it mean that PCV 20 did not meet the non-inferiority criteria?
Sorry, it's complicated. I'm really sorry. That could have been clearer. So I think both of these, PCV 15, PCV 20, are fantastic vaccines. They will prevent the vast majority of pneumococcal disease. Use either one of them. The difference right now, sort of clinically with what you sort of practically deal with on a day-to-day basis, is that, and some of this depends on your contracts. If you stock PCV 20, then you don't have to stock PPSV 23 too. If you stock PCV 15, then you also have to stock PPSV 23 so that you can vaccinate the higher risk kids. So that's really the difference. But in terms of, is one better than the other, I'm not going to say. Like, they both look to be very, very good vaccines. We knew PCV 7 worked great at greatly decreasing invasive pneumococcal disease. PCV 13 did a little bit better. We think both of these vaccines will probably do a little bit better than PCV 13. They're both great vaccines.
So along that same line, with the variability in coverage, should we use different serotype vaccines for each dose, or just pick one and roll the dice?
Just go with what you can. Go with what you're stocking. I wouldn't try and do one or both,
Okay.
or do both.
Thank you. And then with regards to RSV, the first question was the reasoning behind the weight-based dose for Beyfortus.
Sorry, the which?
The weight-based dosing for nirsevimab.
Oh, yeah.
Given
good
that
question.
it's a passive antibody.
Yeah, the weight-based dosing. It's kind of similar. I mean, I guess the way my simple mind would think about it is it's just similar to a lot of medicines where we have to do weight-based dosing, and in this case, this is how it was studied. And so, would 100 milligrams be harmful in the newborn? Probably not. Is it too much? They probably don't need that much. Would 50 work in the 8-month-old? Maybe, but probably not as well as the 100, because the 100 is what was studied. So for 5 kilos or over. So, but in terms of can I give you like the sort of kinetics and all that, not off the top of my head.
Okay. Another question with regards to the RSV vaccine is now that we're giving another vaccine to newborns, infants, are you seeing an increase in sepsis workups related to that as far as fevers?
I have not heard anything about that. We didn't see much in the way of fevers in the clinical trials. And we didn't see much with fevers, if I remember right. I don't remember seeing much data on palivizumab. So I'm not aware of any data showing that. I assume somebody had an experience with that.
Can you explain a little bit to the reasoning behind the initial shortage as the rollout this year? Does that have to just do with manufacturing? Or?
Well, I will share.
And why can't I get guacamole at Chipotle yet?
Yeah, I will share the impetus for that New England Journal perspective that we just got published actually started with an article about nirsevimab and how we were essentially criticizing the company for underestimating demand, because at least my hypothesis, and I don't know how the company decided, I don't know, I wasn't privy to those internal discussions, but at ACIP, multiple times people asked the manufacturer, will you have enough supply? And the answer was always, yes, we will have plenty. And so we went into this season, gung-ho to get this thing out there, and then, there's a shortage. And so the assumption I made was that the manufacturer was basing it on what they thought would be uptake, because they were concerned about vaccine hesitancy coming out of the pandemic. And so it wouldn't be, and so they estimated uptake at about 30% is what they said in their press release, based on prior new immunization uptake. And my counter to that is, this is the number one cause of hospitalization in infants. Why wouldn't parents want that, right? And of course, pediatricians are going to want that. And so I think it was my best understanding based on their press release was that they based what they thought was going to be the demand based on historical introduction of new vaccines. But we haven't had a new vaccine for kids routinely since really rotavirus, right? So as a new product, and that was a much different era. So if they didn't ask me, I would have said it's going to be really high, because parents want to protect their children. They want to do what's best for their children. And yeah, there's going to be some refusal and there's going to be some hesitancy. But when you put those two things in the same room, leading cause of hospitalization, parent wants to do what's right for their children, there's going to be high demand for that.
And anecdotally in our clinic, I felt like, and John, you can speak to this too, but I felt like even parents who were hesitant for other vaccines really did want the Beyfortus vaccine.
Well, yeah, we can talk, we'll talk separately about that, but I mean, I got a lot of questions about, well, do you think more people want it because it's not actually a vaccine? Anyway.
Yeah, you wonder too if it's just that these are things they've heard of because of having a kid in daycare and everybody's out with RSV, and there's the false belief of polio isn't a thing anymore. It's et cetera.
So with number one, the kind of low delivery of the RSV vaccine in the nurseries happening this year, you mentioned that a lot of hospitals didn't have VFC contracts, which actually I didn't know that was the reason, so that was helpful information. But if we don't know, or the mom doesn't know if she received the RSV vaccine, is it harmful if we kind of double dose the infant? They receive it while mom's pregnant and we vaccinate again?
Yeah, good question. So VFC was one issue. The other issue is, in general, hospitals have bundled payments. And so they roll the Hep B vaccine in there because it's cheap, $13 to $15 a dose. $500 a dose, it's not so easy to roll that into their bundled payment. But in terms of if the mom got it, no, there's no harm. The reason that ACIP decided that basically you don't need to, because the baby is protected. And it's not going to cause harm, might give a little additional protection, and there are certain infants who should get it. Ones, if the maternal vaccine was given less than 14 days from delivery, if the mother was immunocompromised, and then certain high-risk conditions that are listed on the AAP website. But basically, any kind of chronic lung disease. Now, the preemies are already going to be eligible, period, because the pregnant person wouldn't have gotten the vaccine. But there are a number of other conditions, like think about meconium aspiration syndrome, where they go home on oxygen. Those kids would probably benefit from both.
And then moving to Tdap and tetanus in general, do you know why, or give more information about why the TD vaccine is no longer going to be manufactured or is no longer manufactured?
I don't know why, and I didn't cover that. I mean, I almost went over on my time on that one anyway. But ACIP did cover that in the last meeting, and so there are now options for the fact that that is no longer on the market, that you can give a different TD vaccine earlier in place of if for infants who are contraindicated receive a pertussis-containing vaccine. Now, the bigger question that I wish CDC had examined was, should that still be a contraindication? Should that contraindication still exist? I actually don't think it should, but it does.
And then can you comment on repeat Tdap boosters 5 years after the 11-year-old dose?
Well, that would be, it probably wouldn't be harmful, but from the recommendation is 10 years, and that's based more on tetanus than it is pertussis. It's not, when they looked at like cost effectiveness of sort of vaccinating the entire population every 5 years against pertussis, it just really didn't, one, wasn't cost effective, and two, didn't decrease pertussis circulation all that much. So anyway, yeah, just follow the recommendations for tetanus vaccination for that one. But you can use Tdap for tetanus vaccination now.
The next question is related to Hep B vaccine, and actually one that I thought was a really interesting question that I struggle with. So sometimes as a general pediatrician, we struggle with the argument for the birth Hep B if mom had prenatal care and mom does not have hepatitis B.
Yeah.
Your argument for that?
Yeah, the Hep B birth dose is really a safety net. We still have babies born that get Hep B. So getting hepatitis B perinatally is really, really bad. 90% of them go on to develop chronic active hepatitis B, and of those, I think roughly 25% will end up dying of the disease, something like that. And so it's really bad, and so we want to do everything we can to prevent that. The birth dose is essentially a safety net. Laboratory errors happen, transcription errors happen, people acquire Hep B late in pregnancy. So there are all these little permutations where even with all the correct stuff, occasionally kids slip through the cracks, and there is no harm. So it's completely safe to give that birth dose. There's really no known adverse events with that birth dose. So there's really no downside. Now, if I have a family where they have good prenatal care, we have a negative Hep B test, they claim no risk factors, it's probably low risk, right? You'd probably need to vaccinate a few million kids in that setting to prevent a case, but it's low risk. So I don't recommend spending too much time on with those families. What I recommend with Hep B birth dose is systematizing it in the nursery. So having a standing order so that it's just part of the routine care, so everybody gets it. And then if there are questions, you can discuss them. But with standards, like having standing orders, having it as part of the routine birth order set, you get rates north of 70% in most places and north of 95% in some. Sorry, I'm doing all the talking. He's a much better
I was going to
speaker
ask
than me,
a question on that. You might have addressed this in your first talk this morning, but is there evidence around the way the question is asked? So not saying, do you want your hepatitis B? I get frustrated when I hear that in the newborn nursery. Do you want the hepatitis B shot versus today's the day we do the hepatitis B shot, and you're still consenting, but it's a different.
Yeah, so that's the presumptive recommendation.
Yeah.
So that's standing orders sort of is implicitly a presumptive recommendation. So the nurse comes in and say, okay, we're gonna bathe your baby and we're gonna give the hepatitis B vaccine, or something along those lines, or your baby is due for the hepatitis B vaccine. Some people aren't comfortable with we're gonna give, but saying you are due for or she is due for is similarly effective.
Perfect.
And giving leeway there, yes, that does introduce like sort of prevarication on the part of the provider. Is it really needed? You know, the parents feeling when
I
someone
remember
says
even
that.
us, when they said, do you want to do that petition? I was like, yeah, but I was like, don't ask, the way made it
No,
too inviting.
It shouldn't be that way. It should be, this is what we recommend.
And actually, there were not too many COVID questions, so I think all of us have lots of experience, unfortunately, with it. So are there resources as far as parent handouts or parent information that you prefer as far as COVID besides like CDC guidelines?
You know, AAP's got a lot. You know, what I'll tell you in general about like patient handouts is, for vaccines in particular, in general, don't try to reinvent the wheel. There is so much out there. AAP, immunize.org, Children's Hospital Philadelphia Vaccine Education Center, Johns Hopkins. I mean, I could go on. We could talk for half an hour on all the great resources out there. So spend half an hour searching through a lot of the good vaccine resources and you know what's out there. And yes, there's a ton on COVID.
I think we might be out of time.
Yeah, I was going to say, there's one closing one that we'll give to both of you. It's because it's along communication and religion too. It says, how do you address the religion argument, i.e., our religion doesn't agree with vaccines?
I'll take this first because I talk a lot about this. So first of all, the world's major religions all endorse vaccination, including vaccines that were developed with fetal cells. And in fact, the Pope Benedict, before he was Pope, wrote the Catholic Church's position on it. And if you're having trouble sleeping some night, just download that one. It's a tome. But essentially what it says is that although it goes into all this, like the evil of this and the evil of that, but essentially what it says is that the good that vaccines do far outweighs the bad. Like if we could have vaccines that weren't developed using fetal cells, great, keep working on that. We don't, so it is much better to vaccinate than not. So that was the Catholic Church's. Other major religions have taken similar positions. And it gets into sort of spiritual versus religious, right? And so most people that are refusing vaccines on religious grounds are doing so either because their state doesn't allow a personal belief exemption, and so they just claim religious exemption, or they are taking their interpretation of, you know, their own spirituality to say, I don't want that vaccine. And there's not a lot of great evidence for what you do in those situations. I think, again, using MI, that kind of thing, working with the family, using a lot of the techniques Mike talked about, in terms of how you communicate with them. Some people, if you are a religious person, sharing that, you know what, I'm religious and I've thought about this and I decided to do it for my children and this is why. But we don't have a good sort of evidence-based technique to say how to deal with that. But the one I've heard probably most commonly from pediatricians who say they're successful when they run into that is to share that they themselves are religious. HPV vaccine has its own set of sort of religious things around it. Oh, this is an issue. It's not an issue for our family. Yeah, maybe it is, but you know that's what they'll say. That's what a lot of families will say. You know, no one has sex before marriage. Some people will use the ploy of, well, you know, you actually can get HPV without, like there are other ways to get it. It's not just sex. So some people will use that argument. Others, the best argument I think is that essentially we shouldn't think of it as an STD because everybody gets it. It's, you know, by some data sources suggest close to 100% of people eventually get infected with HPV. Cervical cancer rates are high in all 50 states, no matter the level of religiosity. So those are some of the arguments I've heard people.
I have this, and I think the cancer vaccine phraseology is really huge. That, you know, and even doing some of those hypotheticals of, well, what if the future partner has, what we're doing is protecting against cancer there. I had this argument with a friend, not medical, that was a religious argument about HPV vaccine, and they ended up doing it when we talked about, so you're telling me that tetanus shot made you feel more empowered to go play with rusty nails? You know, because the fear was giving my child the HPV vaccine is going to make them want to have sex. And so I use the kind of tetanus, rusty nails, it kind of led to silliness. And then I would say, I think just a great answer for any disagreement with something is just tell me more. Because I think, to your point, you might actually find out that they're just using it as that was their box check to get out of the vaccine. But if you actually make them defend their posture without feeling judgmental, they might realize that they don't have much to stand on. They say, oh gosh, I'm Catholic, and I hadn't read it that way, in that sense.
Yeah. I've had good, with the HPV specifically, I've had a good thing. Well, if your daughter, marries, never has sex with anybody other than the husband he marries, and the husband she marries is never had sex with anybody else before her, then you don't need it. And usually mom's like, well, yeah, that's not gonna happen. I can protect my daughter, I can't protect
the other piece is, well, we want to wait, because in our religion, whatever. And the way I put it with that is either use the bike helmet or the seatbelt analogy and say something to the effect of, let's think about this another way. When she rides a bike, do you want her to wear a bike helmet? Oh, yeah, they all say yes, even if they don't. And you say, well, when do you have her put the bike helmet on? Before she gets on the bike or when she's about to get into a wreck? And then for some people that clicks, like, okay, we do vaccines well before we need the protection. And why we think about HPV vaccine any differently than any other vaccine, like that you have to wait till the last possible minute. No, before they have sex. No, you can give it at age 9 or 10 or 11, and they will be protected for a long, long time.